Look at rotator cuff injury or impingement syndrome. The first one is the impingement sign. Impingement sign or near maneuver is with forward flexing of the shoulder, and usually at about this level, if there's been any inflammation around the rotator cuff or rotator cuff tear, patients, you would see, at least in their facial grimace, that they're having some discomfort because the rotator cuff is being pinched off underneath the acromion. The other examination is the Hawkins maneuver, Hawkins sign, with cross adduction and internally rotating the shoulder. What that does, it is taking the greater tuberosity of the humerus and it's basically impaling the rotator cuff on the undersurface of the acromion, which can cause reproduction of the patient's pain in this area from impingement type syndrome. If there's been a complete rotator cuff tear, you can look for a drop arm sign. And that's where you have to take the patient's arm and hold it out to the side. What you don't want to do is just to completely let go and have the arm completely kind of drop. You want to kind of take the arm, gently warn the patient that you're going to let go slowly of his arm to see if he can hold it up like that. And if they're unable to hold it, you need to kind of be protecting them. The other part of the exam is looking for biceps tendinitis, and the way we do that is we turn palm up and holding the arm up this way at 90 degrees of forward flexion, and we ask the patient to resist a downward force on the arm. If that causes any inflammation in here, sometimes that relates to biceps tendinitis. The next portion of the examination is the stability testing. Again, we talked about earlier about the shoulder and how it's unique in that it is it's a joint that highly relies on the ligaments to keep it from dislocating. One of the most common types of dislocations in the shoulder. This was not an emergency, just my wife asked me to bring some pop from Sonic for her. Again, the shoulder is very highly reliant on its ligaments to maintain the humeral head inside the glenoid, inside the socket. And one of the most common types of dislocations is with anterior dislocation of the shoulder. That's where the shoulder is kind of in a throwing type position and the patient abducts the arm, externally rotates, and that pops out the humeral head out of the socket. One of the most common tests to perform on the shoulder to look for apprehension or reproduction of the patient's feeling that the ball is going to come out of the socket is by abducting the shoulder, externally rotating, and it's called the crank test. And if you do this and the patient is apprehensive and they start kind of almost jumping off the table, being worried that their shoulder is going to dislocate, that's called a crank test or an apprehension test. The best position to perform the crank test or the apprehension test on the shoulder, again, is with the patient supine with their shoulder over to the side of the table and externally rotating the shoulder. And you have to be careful. If the patient is apprehensive, you need to back off because you can dislocate the patient even in an office setting. And that's usually most common in patients who have had chronic recurrent dislocations of their shoulder. The other examination that can be performed other than the apprehension test is perform the apprehension test. However, at the point that the patient is having pain, you put a downward force, a posterior force on the proximal humerus to basically relocate the humeral head back into the socket, and then that usually relieves the patient's apprehension as well as pain. However, when you let go, usually that basically reproduces their pain. So this usually signifies that they do have problems with the shoulder dislocation or subluxation, where the humeral head just only partly comes out of the socket. The other examination that can be performed on the shoulder to look for instability is the load and shift test. Again, you need to ask the patient to bring their shoulder again off of the table, and you need to hold their arm up to allow the shoulder to basically be completely relaxed, and you want to place a finger, the middle finger, across the coracoid process right here. The thumb is on the posterior aspect of the humeral head and the index finger is on the anterior aspect. And basically that gives you a judgment of how much anterior and posterior laxity is there in the shoulder. If the patient is very apprehensive, when they're in a lot of pain, they will not allow you to do this. The other exams that can be performed to look for shoulder instability is with the patient sitting up is the sulcus examination, where we pull down on the shoulder. Again, the patient has to be extremely relaxed to allow you to do this. You can see the edge of the acromion, and this is the sulcus sign across here. With severe instability, inferior instability of the shoulder, you can grade these based on how many finger breadths below the acromion is the humeral head drooping. And this would be about a grade 1. Again, this does not always necessarily mean, if you have a grade 1 sulcus sign, does not automatically mean that you have a problem with the shoulder. Again, you would always need to kind of check both sides, and it's just only one piece of the puzzle. The other examination to look for anterior posterior shifting of the shoulders to perform the drawer test, and again you take your thumb and stabilize the scapula, and your index finger is actually on the coracoid process here to stabilize the entire scapular structure, and then taking the shoulder and the humeral head, index finger anteriorly and your left thumb posteriorly, and trying to shift that humeral head into the glenoid. Not as easily of an exam to be done, especially if you have a fairly muscular patient.